Thank you, Mr. Abdul. Thank you. Our next speaker is Dr. Shweta Sonthalia. She's MBBS, MD, MRCOG, and she's currently working as Trust Registrar at Newham Hospital, Bath's Health NHS Trust. She's been working in the field of obs and gynae for over 14 years. Over to you, Shweta.
Thank you. Thank you so much, Dr. Nilofer. Uh, I feel it's a great privilege to present this case today in the symposium. Uh, we recently encountered this case of thoracic endometriosis diagnosed and treated at our hospital. So I thought it would be interesting to discuss about it in the symposium and we can get some take-home messages. So to start with, if we discuss about endometriosis, we all know we are already talking since morning about everything related to endometriosis. So it's a common and benign condition. It's endometrial-like glands and stroma outside the uterine cavity, and it affects 6 to 10% of reproductive age group women. Now, out of it, 12% experience extrapelvic endometriosis, and the commonest location for that is thorax, which was a new learning for me as well, that thorax is the most common extrapelvic endometriotic site. 85% of the cases are in right hemithorax, and around 80% of these are associated with pelvic endometriosis. So it's not mandatory that all the patient who has the thoracic endometriosis, they will have pelvic endometriosis. It's around 80% will have it, and 20% might not have any pelvic symptom, and they will directly present as thoracic endometriosis symptom. The true prevalence is unknown as it is rare and an underdiagnosed disease, which is due to, in part, a lack of awareness of the condition among clinicians. So thoracic endometriosis is the endometriotic-like tissue found in the chest cavity, commonly on the diaphragm, but it can be found on the lungs. And in our patient, it presented like a pleural effusion and chest pain. So thoracic endometriosis leads to respiratory manifestations, and cyclical changes of the endometrial tissue in the thoracic structure will produce the cyclical symptom, the catamenial symptom for the women. Thoracic endometriosis is currently considered to be a manifestation of endometriosis progression characterized by recurrence of symptom within the menstruation and mainly in the right hemithorax, which is the commonest site. Epidemiologically, if we see, it presents at an older age compared to pelvic endometriosis. So pelvic endometriosis, the mean age is 25 to 30 years, the presentation, while thoracic endometriosis present at 30 to 40 years of age. The similar happened with our patient. She fell in this age range. The etiology is not very clear, but it's likely multifactorial, and the pathogenesis is also not yet clear about thoracic endometriosis. If we talk about sign and symptom, usually it is asymptomatic, but if symptom happen, it will be either before menstruation, during the periovulatory period, and following intercourse. Though it's rare, it's present as 4 clinical entities like pneumothorax, hemothorax, hemoptysis, and pulmonary nodule. So our patient was having pneumohemothorax and pulmonary nodule. Symptoms range from trouble breathing, chest pain, right shoulder pain, lung nodule, lung collapse, and coughing up blood during menstruation. Our patient was having chest pain, and when she presented, she was having lung nodule and lung collapse. Feature that distinguish thoracic endometriosis from other disease includes the relationship with the menses, predominant right side symptom in the lung, young age, presence of recurrent disease, and a history of infertility. Our patient is not having any pregnancy since 17 years and she's aiming for it. So to diagnose it, diagnosis and management of thoracic endometriosis is challenged by a lack of research existing beyond the case series. This has prevented the development of national or international guidelines to support the clinical decision-making and standardized care for these patients. There are various diagnostic tests which could be useful to diagnose and to for the differential diagnosis. And the usual modalities are chest X-ray, CT, MRI, and bronchoscopy. So we have done chest X-ray and CT for our patient. In terms of management, the optimal management of thoracic endometriosis would be hormonal therapy plus minus surgery. Preferably, it should be managed at a regional or national level center where we can give the patient multidisciplinary care, as it should be in collaboration with the thoracic chest team as well as the gynecologist. Gonadotropin releasing hormone analog are used as the first line medical management. And the alternatives to this could be oral contraceptives, progesterones, danazol, aromatase inhibitors, and most recently, GnRH antagonist. In terms of efficacy, there is no difference with different hormones, but patient can choose it according to the cost, patient preference, and the side effect profile of different hormones. As GnRH is very effective in terms of suppressing the hormone, but at the same time, there could be a side effect of osteoporosis and menopausal-like symptom, and she might need supplements after 6 months. Discontinuation of hormone suppression therapy is associated with a high rate of recurrence. So if she's on medical management, she should be aware that if we stop that, that symptoms might recur. Surgery should be considered in a patient with refractory or recurrent disease. So if the medical management doesn't work or if she have recurrent symptoms, we have to optimize her health with the surgical management. Surgical management will always be an MDT approach, as it should be done as a team. Thoracic endometriosis and pelvic endometriosis are often concomitant, and MDT approach to treat both thoracic and pelvic disease in a single procedure will provide the most effective outcome for our patients. Medical management represents the first-line treatment approach. When that fails or is contraindicated, definitive surgical treatment for the case of suspected thoracic endometriosis is combined video laparoscopy performed by gynecology surgeon and VATS by thoracic surgeon. Postoperative hormonal suppression may further reduce the disease recurrence, so we can consider giving them hormone suppression after the surgery. So to start with the case report, in January 2023, a 39-year-old patient, para 1 living 1, presented to the emergency department with right-sided chest pain. She was being followed up at our hospital by chest physician for right-sided pleural effusion since April 2022. Chest X-ray and CT scan showed right hemopneumothorax and collapsed right lung, which was managed by chest drain insertion. CT cap showed kissing ovaries suggestive of pelvic endometriosis and pleural nodularity with no evidence of lymphadenopathy or abdominal malignancy. So we got the gynecological review, and on reviewing the patient, we found out that she was having chest pain for 10 years, which was exacerbating during her periods, and minimal pelvic pain she was having, which was relieved with simple analgesics. So it was mainly catamenial chest pain. There was no history of hemoptysis, and we have done the pelvic scan for her in June 2020, which was normal, which unfortunately led to delayed in this diagnosis. She was having regular period. There was no history of menorrhagia. She's having one child, 17-year-old, and she desired future pregnancies. So this is the CT scan image. If you can appreciate the pleural effusion here on the right side. We did the biopsy on right-sided VATS pleural nodule biopsy. We found that it is endometriosis. So these are the CT images showing the hemothorax and the pneumothorax, leading to collapsed lung on the right side. This is the pelvic images showing the enlarged right ovary and the kissing ovaries and the uterine image. And this is the vertical section of that. So for management, we have put the chest drain and relieved the relieve and it was draining the bloodstained fluid, which was removed after 5 days. And repeat chest X-ray showed re-expanded right lung and complete resolution of hemopneumothorax. The VATS pleural biopsy and TAC pleurodesis was done for the patient to generate fibrosis in the pleural cavity. She was advised TBS, but she was not keen in this present admission to undergo that, so we scheduled it for later time. We gave her GnRH analog 11.25 milligrams subcutaneously to treat her endometriosis medically, and she was referred to Royal London Hospital endometriosis specialist for further management. So in conclusion, theories of pathogenesis and epidemiological observation have shown that thoracic and abdominopelvic endometriosis are often concomitant. Our patient presentation corresponds to what is cited in literature, as she was falling in 30 to 40-year age. She was having right-sided chest pain, which is the most common side, right thorax, and she was having hemopneumothorax and pulmonary nodule, which is characteristic of the presentation. Biopsy confirmed it, and we have managed her with the medical management and referred her to the specialist for further care. So the take-home message is, in cases of suspected pelvic endometriosis diagnosed and treated by video laparoscopy by the gynecologist, the diaphragm should be evaluated for evidence of endometriotic disease, as that is the most common site for the extrapelvic endometriosis. These are the references. Thank you so much for your patient listening. Any questions are welcome.
Thank you. Thank you so much for your presentation. Thank you, Shweta. That was quite a novel case, and yeah, brilliantly managed. Thank you. Does anybody have any questions?
Dupanda Chow, did you want to make your comments, please, on rather than the chat? If you turn your camera on.
Yeah, it's a very interesting case scenario. I just wanted to kind of understand that when you say GnRH agonist is the first line, have you tried northisterone with these patients? Because what tends to happen in our unit, I mean, we have a few endo patients who are doing quite well with NET 2.5. So was this tried for this woman?
We didn't try the oral progesterone for her because she was happy when we counseled her about GnRH analog. She was happy to take it. When we counseled her about all other options, she opted for GnRH analog injection because she thought that that will be a better compliance for her, and she was happy to have that. But I agree that we can give any progesterone, and our goal is to suppress the endometrial cells.
Thank you.
Any other questions or comments? So just from I'll ask a question from an oncology point of view. Obviously, as oncologists, we'll explore the diaphragm, and if there's any disease there, resect that. What's your thoughts on what should happen if there's diaphragmatic endometriosis, or if there's thoracic endometriosis? What's been your reading from the literature, and what's the ideal management of these?
They say that any thoracic endometriosis, the medical management is the first line. We can try first medical management because definitely surgery at that site is not an easy job. So if it gets suppressed with the medical management, then we can save her from a complicated surgery. But if that doesn't work, it fail or recur, then I think that is the only choice we are left with. So to liaise with the thoracic surgeons, and then we have to remove
we've had to do that a few times, obviously, for the patients who've had ovarian cancer and lesions, thoracic lesions. So they do an endoscopic thoracic approach. I'm not sure whether you're aware of any management of endometriosis endoscopically, Subal, or any of the other endometriosis
I've never
team?
seen any thoracic endometriotic case to get operated. To be very frank, this is the first case I have seen of thoracic endometriosis.
Aisha, is there a comment from Aisha?
Yeah.
Hi, I just wanted to say that at Royal Stoke Hospital, we have had a few thoracic cases, which we've managed robotically.
Will you turn your camera on, Aisha, so we can see you?
Sorry, my camera's not working.
If not, just carry on. Sorry, go on.
Sorry. So yeah, I was saying that we've had a few thoracic endometriosis cases where we've had spots of endo on the diaphragm, which we've managed to sort out using the robot. You basically spin the robot around, aiming towards that end rather than the pelvis, and then you can do excision just very gently, or you can do ablation.
Okay, sounds good. Yes, I mean, realistically, an excision would be a good idea. That's fine, but I mean, certainly from an ovarian cancer point of view, and I can't see any reason why it couldn't be transposed to the endometriosis. But we will liaise with the cardiothoracic surgeons, and they've often found endoscopic, management as an appropriate way forward. But no, thank you. That's interesting.